Greetings and welcome to today's SACS Healthcare Communications webinar on recurrent ventricular fibrillation, new strategies for challenging patients. My name is Dave Clark. I'll be your host for today's event. Now, before we get started, there are just a couple of things I'd like you to know about. Concerning the audio, today's webinar is listen only. That means that you can hear us, but we can't hear you. But that doesn't mean that today's event won't be interactive. We'll have a Q&A session at the end of the webinar, and you can type your questions at any time into the questions pane. The questions pane can be accessed by clicking the little question mark icon that you'll see on the right side of your screen. Just click that icon, type your message, and click send. If, however, you have a control panel on your screen, you'll see the questions pane in that control panel instead. And by the way, you can also use the questions pane to communicate with me if you're having any technical problems, including audio issues. Just let me know what the problem is, and I'll do my best to help you out. We're really interested today in your thoughts and questions on this topic, so be sure to get all of them into the questions pane, and we'll try to answer as many of your questions today as we can, I promise. All right, well, let's get started with today's presentation on recurrent ventricular fibrillation, new strategies for challenging patients. Our moderator today is Christine Lux, a clinical educational specialist at Overlake Medical Center in Seattle, where she facilitates patient care services and orientation for nurses. Prior to that, Christine was a cardiology nurse specialist, and co-chair of Code Blue Committee at Harborview Medical Center in Seattle. As our moderator, Christine will be leading us through the rest of today's event. So Christine, over to you.
Good morning, afternoon, everyone. Thank you, Dave, for your very kind introduction. The title of today's webinar is Recurrent Ventricular Fibrillation, New Strategies for Challenging Patients. Speaking today on this very timely topic is Nicole Kupchik and Tim Fallon. Nicole has practiced as a critical care nurse for over 20 years. About 15 years ago, she began working at Harborview Medical Center, a change that spurred an interest in resuscitation. Shortly thereafter, Nicole was part of a multidisciplinary team that was one of the first in the United States to implement therapeutic hypothermia after cardiac arrest. As part of this effort, Nicole was responsible for protocol development and has published numerous papers on the topic. In 2013, Nicole founded Nicole Kupchik Consulting and Education. Tim Fallon, our second speaker, has provided ECG education to over 75,000 healthcare providers nationally and internationally. The American Heart Association in the 1997 ACLS textbook has recognized Tim for his approach to teaching 12-lead ECG. A published writer, Tim has authored and co-authored textbooks, including the 12-lead ECG in acute myocardial infarction and the book 12-lead ECG in acute coronary syndromes. Nicole has disclosed the following affiliation. She's on the Speakers Bureau for Physio-Control Stryker, Medtronic, and Mallinckrodt. She's also a consultant for Physio-Control and Stryker. Tim has disclosed the following affiliation. He is also on the Speakers Bureau for Physio-Control and Stryker and a consultant for Physio-Control and Stryker. This educational activity is approved for 1 contact hour. As you can see, the accreditation statement is disclosed on this slide. A link to obtain CE credits will be available at the conclusion of this webinar. Support for this educational activity is provided by Physio-Control. It is now time to hand over this webinar to one of our experts, Tim Fallon. Tim, are you ready?
I sure am. Thank you, Christine. So we have a lot that we want to cover today. And before we jump into it, let me just cover some of the learning objectives that we're going to be addressing. So we're going to discuss the importance of performing high-quality CPR, and then really starting to look at defibrillation success in patients with refractory or recurrent VF. We're going to describe some evolving EMS and hospital-based treatment strategies for these patients. And then we're going to look at the new evidence on the role of mechanical CPR as a bridge to some more advanced circulatory support in the Cath Lab. So with that out of the way, here's what we're going to do. We're going to kind of describe a patient situation for you. And we're going to begin it in the EMS environment, work it through, and then I'm going to hand it off to Nicole, and she's going to continue in the hospital. And here's our scenario. It's just a gorgeous day. Our soon-to-be patient is getting a little bit hungry, heads on over to the food trucks, and while he is standing in line, he experiences sudden cardiac arrest. Well, there's folks all around there. Somebody dials 911, some folks start doing chest compressions. BLS arrives quickly, they are on it, they're doing great CPR, they apply the AED, the shock is delivered. Before you know it, the ALS crew gets there. Now, the ALS crew, the BLS crew, they have worked together before without even speaking. They know their roles, and they are running like a fine-tuned machine. Well, everything is going perfectly. However, the patient remains in VF. Despite everything, they're still in ventricular fibrillation. So what do we do? Well, now this may seem like a obvious question, but here's why I want to start with this. For the past several years, the thing that has produced 2 times, 3 times, sometimes 10-fold the success rate in the pre-hospital environment has been the recognition that maybe the most important thing we can do is, instead of just getting on the scene, doing a couple things and moving them on to the hospital, that maybe is to stay on scene. Now it's called stay and play. It rhymes, it's cute, but really nobody's playing. Really, we're talking about staying and working. It's that whole team-based thing that just emphasizes incredibly high quality CPR and defibrillation. That works. It has worked so well that now it almost may seem like a non-starter if we were to even suggest that there's potentially a subset of patients that might actually benefit from not staying on the scene, but might actually benefit from a somewhat early transport. So just wanted to acknowledge that right up front. We're aware of what's caused the success. We're saying continue with that, but we just want to put a few things out there for you to think about. Now, just another issue that I want to touch on right before we jump into it is recurrent and refractory VF. They sound kind of the same. And what we're going to say is, initially, we're going to lump them together, but there's a reason that we're going to distinguish them. So here we go. Recurrent ventricular fibrillation. Well, as you see from the image, it's like, so hey, they are in vfib, a shock is administered, they are defibrillated, they are no longer in ventricular fibrillation, whether it's ROSC, whether it's PEA, whatever, they are no longer in VF. But as time passes, they return back into ventricular fibrillation, versus someone who, despite our best efforts, they have remained in ventricular fibrillation. We're going to refer to that as refractory. And as I said, initially, we're just going to lump those two together because, as we're going to see, the underlying cause, the underlying issue for both of those is probably the same. So why am I even bother differentiating them? Well, there is a reason for that. And at one point, we're going to delve a little bit deeper into refractory. But for now, we're going to think of them as the same entity. So we're back to our patient. The question was, what can we do? Why is this person still in ventricular fibrillation? Well, it's always nice to be able to answer that question. It's like, what is the underlying cause here? We have a certain approach, we have a certain protocol, and if that's working, fantastic. But what if we're doing everything right, but we're just not getting the results that we're looking for? Hey, it's time to take a step back, reassess, and say, what's going on here? What is the underlying cause? And with a lot of these patients, the underlying cause is that, well, the reason they went into cardiac arrest in the first place was an occluded coronary artery. And you see that little red arrow there, and that artery should be visible beyond the arrow, but it's not because they have an occlusion. So for some of these folks, that's what put them into cardiac arrest in the first place. And for some of them, that's why they're still in VF. Now, if that's the underlying problem, obviously defibrillation isn't going to address that. We're defibrillating patients. We're affecting electrical flow through their muscle. Defibrillation is great at that. Defibrillation does not reperfuse anyone, though. Okay, so if there is a coronary artery occlusion, well, then we start asking ourselves, is reperfusion an indication here? Now, generally, when we start thinking about reperfusion, we're thinking about STEMI patients. And well, gosh, there's ST segment elevation here. Now, we understand that just because there's ST elevation doesn't mean they're having a heart attack. There's a lot of causes of ST elevation, but if we believe they are having a heart attack and we believe this elevation is from that heart attack, the reason we're so interested in ST elevation in the first place is because that ST elevation correlates with a certain type of occlusion. And the type of occlusion that it correlates with is a complete coronary artery occlusion that's a fibrin-rich clot. Those patients respond very well to immediate reperfusion. So hang in there with me. When I introduce the idea of immediate reperfusion, just kind of wanted to step back and say, all right, here's a classic indication, good old STEMI. In distinction to some acute MI patients who are having a heart attack right before your eyes, you do a 12 lead on them, there is no ST elevation. Well, that's still a heart attack, but folks that don't have ST segment elevation tend to have a different type of clot. It's probably a partial occlusion. Now you see the yellow part there, that's the lumen, or excuse me, that's the wall of the coronary artery. That dark area in the center, that's the occlusion. And you can see that there's the opportunity for some blood flow around it. Now, these non-STEMIs can be lethal heart attacks. They're not a lesser kind of a heart attack. They're a different kind, and they respond well to medical management. Okay, so we started off thinking about who in cardiac arrest might benefit from reperfusion. So there's a quick review of STEMI and non-STEMI, and that's how it used to be. Then the next step occurred when folks started to realize, you know, we're not treating the ECG, we're treating this coronary artery occlusion. And I'll bet there are some ECG findings, some patterns, that even though there's not ST segment elevation, that they require immediate reperfusion as well. And as a group, we call those the STEMI equivalents. Here's one of them right here. These are De Winter T waves. There's no ST segment elevation, a little bit of depression there, as you can see in V2, 3, and 4. Just turns out, side note, 3% of left anterior descending occlusions tend not to have ST elevation, but a little bit of depression with these tall T waves. They would be candidates for immediate reperfusion as well. So these STEMI equivalents, they don't have ST elevation, but they are candidates for immediate reperfusion. So the window has opened up. Well, that continues. Who else might be a candidate for immediate reperfusion already? Well, this one's straightforward. If it was an out-of-hospital cardiac arrest and you obtained ROSC and you do a 12-lead ECG and you see a STEMI, well, hey, that's a STEMI, sure. Now's where it gets interesting. Out-of-hospital cardiac arrest with ROSC, you do a 12-lead ECG and there's no ST segment elevation. Well, according to the guidelines, it is still reasonable to consider reperfusion for these cases. So remember, it's not the ECG that's the thing. It's the underlying problem that we're trying to address. So all of that was to point out that as we've evolved, it's not a simple black and white. The question is, who really would benefit from immediate reperfusion? Now, these folks have experienced ROSC. The next group then is the people that we're going to address. A quick word about the ROSC crowd, just to give some numbers to it, alrighty? So post-resuscitation, you do a 12-lead ECG, and you don't have ST elevation. How many of those, if you went to the Cath Lab, how many of those would you find culprit lesion? Well, a fair amount, as you can see right here. What that means is, in just round numbers, low end, ROSC, 12-lead, no ST elevation, at least 1 out of every 4 of those would you'd probably find an occlusion, maybe half of them. And Nicole is even going to mention another study where it might be over half. So this is a significant group of folks. Now, I don't want to overstate my case. Remember who we're talking about. At this moment, we're talking about out-of-hospital cardiac arrest. Okay, so that's a subset of all the cardiac arrests we might encounter. And not everybody with an out-of-hospital cardiac arrest was in arrest for cardiac reasons. Okay, we get that. And right now we're talking about recurrent VF, all right? Now this is some numbers on maybe the initial presenting rhythm. Some of those PEAs, some of those asystoles, as you continue to work them, they'll get moved over to the VF category. But the point being, that if you just look at simply how many of these folks have some coronary artery disease that's significant, it's a pretty high percentage. So it's reasonable to start thinking about reperfusion even without the classic 12-lead ECG ST segment elevation finding. With that said, now you're in that situation. You're working this cardiac arrest. This person seems to be stuck in VF. What do they need? Well, reperfusion is what we said. That's a change. You talk to a lot of EMS agencies. Now, this is a system of care issue, okay? This affects everyone. But what's brought success is the idea that we are bringing the office to them. We're going to work this on the scene. But the potential now is to say, in some of those folks, would it make sense to just bring them to the Cath Lab? That's what we're going to do. And we're going to talk about those kinds of strategies. So I'm preparing to hand things over to Nicole, but I told you that before we looked at the hospital component, we kind of revisit this recurrent versus refractory. And how often do you see recurrent vfib versus how often you see true refractory? Well, it's pretty skewed. In one study, if you look at how many people had at least 5 episodes of recurrent vfib, it was like 37%. If you said, how often do people have at least even 1 episode of recurrent VF? Some pretty high numbers there, okay, over 75%. Versus, this is surprising potentially, how often do you see true refractory VF? Less than 1%. And that was a pretty large study. So you might be thinking, wait a second, that's just not consistent with my real world experience. It seems like I've seen lots of cases of refractory VFib that no matter what we do, they are always in VF. Well, maybe what's going on is really just a function of when we looked. Now you look at these 2 ECGs, and the one on the left, pre-shock, the one on the left, post-shock. You might say, well, look, hey, that's refractory VF. But once we shock them, and if we do a 2-minute round of CPR, it could be that once we hopped on the chest and started doing CPR, that actually the defibrillation was successful, but now they have refibrillated by the time we do our reassessment a couple of minutes later. Now, how long would you need to terminate the VF? Well, it might be surprising. You might have a successful shock that really only terminated the VF for just a second or 2. And it would be very easy to assume that that's refractory. Now, just while we're on the subject, take a look at this. VFib, shock, boom, right into perfect flat line here. Just so we're on the same page, this is actually a successful defibrillation. Now, it's not a successful outcome, but the defibrillator's job is to end ventricular fibrillation. That's what it's supposed to do. And if it ends that fibrillation, even if it's asystole, that shock was successful. So remember, even if you don't have ROSC, that doesn't mean that somehow the defibrillation was unsuccessful. So kind of getting back to that refractory situation, all right? Now, looking at the recurrent, you see we had VFib, there was a shock. The shock was successful. They went back into VFib. So the defibrillator did its job. If they keep going back into VFib, looking at better defibrillation strategies probably isn't going to be the fix here. But you might ask, well, what about this situation? What if they truly had refractory VFib? Well, if there was ever a time when you would say, all right, as we're thinking about this coronary artery occlusion, as we're possibly preparing them to take them to the Cath Lab, is there anything we can do in addition to that that might increase the likelihood of defibrillation success? Well, according to the guidelines, escalating energy, absolutely. And here's a simple little thing to try. If you're in that situation, as we mentioned, it's pretty rare, but if you're in that situation where you think you have genuine refractory VF, maybe moving from an anterior lateral to an anterior posterior pad placement, I mean, we're just trying to say, all right, why is it that the defibrillator hasn't fixed the underlying electrical problem? So if that is truly the case, then that warrants consideration. But as we said, there are some differences, this being one of them, but the the commonalities are going to greatly outweigh them. Between refractory and recurrent VFib, what they have in common is the high likelihood that they have a culprit lesion. So if we're then going to identify those patients, take a step back and say, all righty, we're going to do something a little different here. We're not taking the hospital as a last ditch effort. We're saying this subset of patients may genuinely benefit from PCI. Okay, what that implies is now that you are the bridge to more definitive care. And one of the reasons we focus on staying on the scene is it's easier to do super high quality CPR on the scene. It's an easier environment, you have better biomechanics, you can stack the box with lots of people to rotate doing chest compression, so it's just flat out easier to do high quality CPR. And the other consideration when we're en route is the safety of the team. So if you've ever considered mechanical CPR, this would be the time to think about it. Now, the indications for mechanical CPR, well, moving a patient. Now, here's what's going on. They had been doing CPR. They have to take no more than a 10-second pause. So they're just going to take someone, not down an entire floor, they're just going to take them down to the landing of a single floor. That took them 10 seconds. Then they've got to hop back on the chest and do another 2-minute round of CPR. Versus if you have mechanical CPR, at this point, you're able to continuously move the patient. You can focus on safety as you're going down the stairs. So it saves time, it's safer. Again, Nicole is going to explore some of the studies regarding mechanical CPR, but purely from a practical point of view, when we start to think about moving these patients to more definitive care, it's our responsibility to provide high quality CPR, and mechanical CPR is going to be a big help for us here. Okay, so I'm going to recap what we said, get ready to turn it over to Nicole. First thing, hey, let's stick with what's worked. All right, we're going to continue to provide high performance, team-based CPR and manage these cardiac arrest scenes as best that we can. But we're going to begin to think about the possibility of recurrent refractory VFib and consider that maybe if they're not responding to our treatment, that maybe there's an underlying cause here. Maybe these folks need something more. Then this is a systems of care issue, so you have to know the resources in your local area. What are the options for those kinds of patients? And even when the options are present, we're not saying it's every single patient that's going to qualify. There'll be some eligibility, so you have to decide, all right, given the situation, I want to treat the underlying cause. I know what options are available in my area. Will this particular patient meet that eligibility criteria? If so, then it's like, all right, let's get them there and let's provide the best, highest quality CPR we can, even as we load them into the truck, as we're driving, as we unload them from the truck, because this is going to be that bridge to accessing the more definitive care that we've been talking about. So there's some aspects of the pre-hospital environment, and I'm going to hand it off to Nicole now, and she's going to handle it from the hospital environment. Nicole?
All right, thanks, Tim, and hello to everybody out there. I'm coming to you from Seattle, Washington. So, all right, so what I want to do now is just kind of explore the idea. So Tim had this patient pre-hospital. So pre-hospital, they're kind of taking a new approach where maybe instead of staying out in the field and working on the patient, they get to the hospital as quickly as possible. And a lot of things have to go right for us to have, increased survival and improved outcomes. Is the patient's got to have good bystander CPR. That is key. The early defibrillation. So kind of, knowing where your community defibrillators are makes a huge difference. Other things, so quick transport. So we know that quick transport to hospital is going to be absolutely key. But now we're asking the question, should we take these patients to the Cath Lab? And instead of thinking of treating the symptom, so the symptom would be vfib, ventricular fibrillation. But maybe should we focus more now on actually treating the cause of the issue, which is causing the symptom vfib. So getting them to the Cath Lab and opening culprit lesions. And so it's a whole new way of thinking, but we need to focus on the basics. The basics have to be right. They've got to get bystander CPR. We've got to get them defibrillated as early as possible, and just really minimize any interruptions in compression. So what matters most? That bystander CPR and getting them transported. And shocked as quickly as possible. So, all right, so let's say we've got this patient now. They're coming to the emergency department. So, patient's continuing into ventricular fibrillation, so you can kind of see the rhythm here. End tidal is 20s to 30s. So what do you guys all out there think about end tidal 20s and 30s in a patient who's in cardiac arrest? Actually, 20s and 30s looks really good. So that's basically a physiologic way of the patient saying, I'm here, you're doing a good job, get me to the cath lab. And so doing chest compressions, they get an airway placed. And one of the things I want to say about airway, if you guys were on my last webinar, is you need to really make sure you do not interrupt compressions to place airways. This is a huge, 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 huge deal. So, all right, so we keep shocking the patient. We've escalated the energy. We're shocking with 360 joules. So now what? So now what do? You've got this patient who's in vfib. They've got a good end tidal, so they're kind of telling you, I'm here. What do you do now? And so now the question is, why do patients go into vfib? So what's the reason? And if you kind of think like big picture, okay, you think about people that go into vfib, you might think like long QT, you might think hypertrophic obstructive cardiomyopathy, cocaine-induced MI, sometimes they go into vfib. But for most patients, over 85% of them, it's actually a lesion in their coronary artery. So again, the focus needs to be more on how do we fix the problem instead of only treating the symptom. And the symptom, again, being ventricular fibrillation. So should the patient go to the cath lab? We've got an end tidal, it's in the 20s and 30s. We're giving good quality CPR. We're shocking like crazy, but we can't get them out. And so that's the big question that's being asked nationally. Should we start taking these patients to the cath lab? So how do we get them to the cath lab, transport, and give good high quality CPR while transporting the patient, but also while they're in the cath lab? And so there's been a big movement to mechanical CPR. And so if you ask yourself, when is CPR challenging? Well, anytime you've got a long code, it's going to be very challenging. People get really tired. I've been in codes where actually you start to run out of people who've got the energy to give good quality CPR. In the back of a moving ambulance, it's almost impossible, and it's dangerous for the medics to give CPR in the back of a moving ambulance. The cath lab, there's really good data, especially out of Tucson from Carl Kern, showing that it is really difficult to give high quality CPR in the cath lab. We know CPR quality drops significantly in a hospital bed, because if you think about how CPR might be different in the pre-hospital world versus the hospital world, in the pre-hospital world, most patients are providing CPR to a patient who's laying on the ground. But in the hospital world, the patients are on a bed, on a mattress that's bouncing up and down, on a mattress that's elevated. And it's really, really, really challenging to give good quality CPR. And then finally, the morbidly obese patients are very, very challenging. And so we're asking the question, can mechanical CPR help us? So should we be rethinking the basics in the way that we provide chest compressions? And so there's kind of this whole big idea in movement that's called eCPR. So I'm guessing a few of you out there have probably heard of this, but eCPR stands for extracorporeal cardiopulmonary resuscitation, and it's comprised of 3 components. So the first component would be using mechanical chest compression devices to deliver the CPR. The second component would be taking these patients to the cath lab to, again, treat the kind of the root of the problem versus just the symptom. So get these patients to the cath lab. And then the third component, which a couple of facilities across the country are starting to do, is ECMO. So they're placing these patients on extracorporeal membrane oxygenation to basically, it's kind of like cardiopulmonary bypass to support the heart and lungs, while we can get these patients to the cath lab and get their artery open. And so, so this is kind of a new movement. Now, some facilities are doing kind of the first 2 components of mechanical CPR and PCI. And then there are a few centers across the country, namely Minneapolis, Philadelphia, San Diego, Chicago, that are actually putting patients on ECMO, either in the emergency department or they'll put them on ECMO in the cath lab and supporting the patient's myocardium while we do PCI. So again, this is called eCPR. Okay, so what I'm doing now is I'm playing a video. Unfortunately, we don't have sound for it, but I'm playing a video. This was out of a reality show in Europe, and it was a video where they take this patient. This patient presents to the emergency department via EMS, and the patient's having an acute coronary syndrome. And you can kind of see they're getting the patient situated over to the stretcher. And it looks like our video has kind of paused there a little bit, but getting the patient situated over to a stretcher, and they're talking to the patient. The patient's completely alert, kind of getting the patient, they're gonna do a 12 lead on the patient, so you can kind of watch. And I think most of the video is in Norwegian anyway, so so the sound I'll kind of narrate for you here. But anyway, but what's happening is, you know, they're doing a 12 lead EKG, acquiring it. And then let's see what's going on now. Now the patient's kind of losing consciousness. Now the patient goes into vfib. So right in front of them, the patient goes into ventricular fibrillation. And they're shocking the patient. So they just shock the patient there. And they're kind of interviewing the nurse and talking about what's going on. It's part of the reality show. But they're shocking the patient again. And this has been, the video has been edited, so it's not, you know, all in real time, but you can see, okay, they just shock the patient again. And one of the things that's, actually there was just a new study published on this, but one of the things that's really kind of confusing is when patients kind of have those agonal respirations and you're kind of second guessing yourself, like, oh, you know, is this patient, do they have a pulse or don't they have a pulse? But agonal respirations are actually pretty common in the onset of ventricular fibrillation, and actually we know it's a good sign. So it's actually a good sign if patients have agonal respirations. That's been associated with higher outcomes. And so anyway, you can see what's happening here is they're doing CPR. They continue to keep shocking the patient. So they shock, they get right back on the chest. They're providing high quality CPR. They're managing the airway, and now they're placing a mechanical chest compression device. And so you can kind of see they're placing the device, and they really minimize the off chest time while they place the device. So now the patient's going to get mechanical CPR. So you can see they're starting the mechanical CPR. And here we go. So they're still doing mechanical CPR. And then now they're having a discussion, you know, what should we take this patient to the Cath Lab? Because if you think about it, you know, most patients, the reason they have a vfib arrest is because they've got a culprit lesion. And so you can see they're doing mechanical chest compressions. And then having the discussion, should we go to the Cath Lab? And so here we go. So what you're going to see here in the next minute or so is them actually kind of packing the patient up and moving the patient, transporting the patient to the Cath Lab. And so you can kind of see the teams all kind of working together there. And they're whisking the patient off to the Cath Lab. And this is kind of a newer movement, you know, because I'm going to be honest, a lot of cardiologists are very hesitant to take patients with ongoing CPR to the Cath Lab. And it's honestly for good reason. And if you kind of think about like why would you second guess it? Like why, you know, wouldn't we take the patient to the Cath Lab? And, you know, the reason for a lot of cardiologists is that they have to publicly report all of their outcomes from the Cath Lab. And so there's kind of a movement now. There's a group of physicians working collaboratively with CMS to see, can we exclude these patients from publicly reported outcomes? Because if you can kind of think about, like, so who would have a better outcome? A patient who walks in with a STEMI or comes in through EMS with a STEMI, or somebody who goes to the Cath Lab with ongoing CPR? And of course, the patient who walks in with a STEMI is going to have better outcomes. But the patient who has the cardiac arrest, they arrest for a reason. And so, so we're asking the question, can we exclude these patients from publicly reported outcome data? And so let's I want to circle back to the whole idea of mechanical versus manual CPR. So one of the studies that was done a couple years ago out of Europe included over 2,500 patients. And what they did was they divided the group. 1,300 patients got a mechanical compression device, and 1,289 got manual CPR. And what they did was they assessed 4-hour survival, comparing the two groups, and then they did follow-up at 6 months to see if there were any differences. And what this study showed was that there was no difference in 4-hour survival. So you can see here the 4-hour survival was exactly the same. The ROSC rates were pretty similar as well, so a little higher with the mechanical CPR group, but nothing that was statistically significant. And then they looked at the survival to discharge from the ICU and then of course to the hospital, and again slightly higher in the mechanical mechanical CPR group, but was not statistically significant. So, and then they looked at 6-month outcomes. And so what they found in this study was that there was no statistical significance in manual versus mechanical CPR. But here's the deal, and I want you to kind of take a step back from this and think about the study design. There's absolutely no way to blind mechanical CPR versus manual CPR. And so if you were in the group that was providing manual CPR and you knew your CPR was being watched, how do you think you'd perform? Do you think you would perform better? Or do you think you would perform kind of average, the way, you know, a lot of us, and we all know, I mean, it's kind of the secret that we all know about, is that our CPR quality in general pretty much stinks in hospitals. And so these groups knew that their CPR was being monitored. And so what they found was that basically they were comparing manual CPR, which ended up being almost perfect, to mechanical CPR. And so the outcomes, there really were no differences. But the question I want to ask is, you know, what if you throw this in and people don't know their CPR is being watched or monitored, you know, or measured, you know, would their CPR be a little better? So bottom line, in this study, this was called the LINK trial, perfect manual CPR compared to mechanical CPR had about the same outcomes. So there you go with that. Now, this was a brand new study that was literally just published, I think just a couple, like not even a month ago. And this was comparing mechanical CPR. So the question was, does mechanical CPR applied early make a difference? And so what they did, this was a randomized control trial where they placed the mechanical CPR device on site, so on scene, versus in an ambulance, so versus waiting till they get to the ambulance, and they compared that to manual chest compressions. And so again, it was they were comparing the mechanical CPR device applied on site versus on the ambulance. And this was called the MECA trial, MECA standing for mechanical cardiopulmonary resuscitation versus standard manual CPR and out-of-hospital cardiac arrest by emergency ambulance crew. That was a mouthful there, but what they found, if you kind of look over here at the graphs, is this white bar here indicates early mechanical CPR. The gray bar is manual CPR, and then the black bar would be late mechanical CPR. And there was definitely a difference in the ROSC rates, or return of spontaneous circulation, when the mechanical CPR device was put on early. And then when you look at discharge survival, there was definitely statistically significant benefit of putting the mechanical CPR device on early. And then when you look at 30-day outcome, again, statistically significant improvements in putting the mechanical compression device on early versus manual or late mechanical CPR device placement. So the key is if you're going to use a mechanical CPR device, put it on early versus waiting, you know, until you're advanced in the code. Now, this is another study that was, again, just published, and they were looking at the safety data between the AutoPulse device, the Lucas device, which are both mechanical CPR devices, and then manual CPR. And they divided the injuries into 3 different classes. So class 1 would be patients who had life-threatening injury. A class 2 would be somebody who had maybe some visceral organ damage. And then class 3 would be just kind of broken ribs, which you kind of expect with CPR anyway. And what they found when they looked at the data was the Lucas came on top over the other 2 modes with less injury. And so there was less risk of injury with the Lucas device versus the other 2 methods that were provided. And so, so we know that it's safe, so we know mechanical CPR is safe, but I can't say enough about placement, because one of the injuries that was reported with the mechanical CPR device was a liver laceration. And I have to say, you know, you have to wonder, if you've got a liver laceration, are you putting this device on in the right spot? And so I can't say enough about, if you're doing manual CPR, correct hand placement. If you're doing mechanical CPR, you've got to get the, especially with the Lucas device, the piston placed in the right spot on the chest, or else you may see organ damage, which could have been avoided. So, all right, so now we're kind of back to the idea, you know, should we take these patients to the Cath Lab? So what does OHCA and what do our guidelines say? So what our guidelines say is if you get ROSC, you know, get a 12 lead, and it's a class 1 recommendation to do that. If you have a STEMI on the 12 lead ECG when you get ROSC, absolutely those patients should be going to the Cath Lab. Now, another thing that OHCA is saying, it's a class 2A recommendation. go to the Cath Lab regardless if they're awake or not. So if they're comatose, if they're awake, it doesn't matter. Take these patients to the Cath Lab. You should be doing targeted temperature management as well if they're not awake. And then some kind of interesting data. So this was a case series that showed that it's a no-brainer. If a patient's got a STEMI post-arrest, 95% of them all needed intervention. So they needed an intervention. That's a no-brainer. But the really scary thing is the ECG doesn't always seem to tell the story. So in this case series, 58% of patients who had a cardiac arrest didn't show ST elevation on their 12-lead ECG. And so that's kind of a scary thing. So we shouldn't be solely relying on the 12-lead to decide if these patients should go to the Cath Lab. And if this is the algorithm that's used to kind of risk stratify patients who actually have ROSC. So these are patients who have ROSC. And what they're saying, quickly you should decide, do a 12-lead. If they get ROSC, if they've got ST elevation, no brainer, go to the Cath Lab. But what they're saying is there's, patients with unfavorable resuscitation might be a pH of less than 7.2, a lactate greater than 7, an age greater than 85, greater than 30 minutes to ROSC. But we're actually questioning a lot of these things now. So a lot of these areas where we kind of thought, not really sure, according to the American College of Cardiology and AHA, if we should take these patients to the Cath Lab, we're really questioning. And so I'm going to kind of jump into the data and kind of look at why we're questioning and who we're questioning. So and this would be, of course, the ongoing CPR patients, because there aren't any really true official recommendations for them. So this is a case, a 56-year-old who had an out-of-hospital cardiac arrest, and this was one of those patients who we got him back, lost him, got him back, lost him. He got 4 milligrams of epinephrine, but kept losing his pulse. And so they do a 12-lead ECG, and here's his 12-lead. So really confusing 12-lead, right? So he's got a big, gigantic right bundle branch block. What should we do? So would you guys take this patient to the Cath Lab? Because the ECG doesn't say whether to do so or not. And this is a patient who keeps arresting and getting ROSC, arresting and getting ROSC. So anyway, so what they decided to do was to take the patient to the Cath Lab. Now this picture isn't from this patient, but what a lot of facilities are doing now is they're placing the patients on mechanical CPR, mechanical compression devices. And you can see this patient is actually in vfib arrest while they're doing PCI. So this patient is having PCI performed while they're getting chest compressions. And a lot of people are just asking, should the endpoint of resuscitation be in the Cath Lab artery open? And if you can't get them out of vfib once you get the artery open, maybe that's the time to call or to end of ventricular fibrillation resuscitation versus just calling it while the patient's actively in VF without trying to do anything, to intervene. So this is actually a Cath Lab a patient in the Cath Lab, and you can see they've got the piston mechanical chest compression device on the patient. And I don't know if you can see this, but up here, the patient's got a really big LAD occlusion. So a very large LAD occlusion, and they're doing mechanical CPR in the Cath Lab while they're trying to get that lesion opened. And this was that patient with a big, gigantic right bundle branch block, but really nothing else on the ECG that really told the story. So they're doing mechanical CPR, they're stenting the LAD while CPR is being done, so while chest compressions are being done. And here you can see the device is no longer moving because they got the LAD stented and were able to successfully defibrillate this patient out of ventricular fibrillation. And so this is the whole idea, is move from just kind of treating the symptom being vfib, to treating the problem, the root problem, which would be an occluded coronary artery. And so to do this, of course, you've got to have a couple things in place. A lot of facilities are finding better success with mechanical CPR, and then of course you've got to have a cardiologist who's comfortable doing this. And so so this is definitely a new way of thinking. So this is this next case is a very interesting case that's just completely different. So 49-year-old, a female who's got a remote history of cancer, nothing active, but had been a smoker, had progressive shortness of breath, chest pain, and then had a witnessed cardiac arrest. So she was another one of those patients where they lost her, got her back, lost her, got her back. So she kept arresting, and then they would get ROSC, and then she would rearrest. And so now she's in cardiac arrest. They're doing mechanical CPR. They put the mechanical CPR device on her. Her end tidal is greater than 30. So what do you guys think? Should we just should we call it, or should we take this woman to the Cath Lab? So what do you all think out there? Well, this cardiologist decided to take the patient to the Cath Lab. So here we go. So there's this is a video showing mechanical CPR being done while they're transporting the patient. So they're actually in the elevator doing mechanical CPR. She's in full cardiac arrest. This is a picture of them going down the hallway with the mechanical CPR device, providing high quality CPR as they're getting the patient to the Cath Lab. Okay, so now they get into the Cath Lab and they find that her coronaries are completely clean. So her coronaries are totally clean. So actually this is another picture, or another video showing them going around a corner getting into the Cath Lab. So they get into the Cath Lab and they find that her coronaries are totally clean. And so then they're asking, well, geez, if her coronaries are clean, why is she arresting? And so this video, what you can see, they decided to angio her pulmonary arteries, and they find that she's got a massive pulmonary embolism. And so you can kind of see here from the video, they're shooting dye up her, let's see if we can get this to play again, shooting dye in her pulmonary artery, and hardly any perfusion is getting to her lung. And so then what they did was they did a mechanical thrombectomy. So they actually pulled the clot out of the lung, and they did TPA right to the clot itself. And you can kind of see the after results. Oops, I did that video. Let's see, hang on. Let me go back and see if I can get that video to play. This video does not seem to, oh, that is a bummer. Okay, well, what you would have seen there, if you could have seen the video, this is, oh, here we go. Maybe we can. There we go. That was my fault. Okay, but now what you can see is when they shoot the dye, beautiful perfusion to that lung. And guess what happened once they reperfused her lung? They got her out of ventricular fibrillation. And let me play the video again so you guys can see this, because this is really cool. So you can see they're shooting dye into her pulmonary artery, and they reperfused her lung beautifully by doing mechanical thrombectomy and TPA to the site. So a couple things was she had, so what pulmonary angio revealed was a massive pulmonary embolism. They did the pulmonary thrombectomy, and they used the ECOS catheter and infused TPA, again, right to the pulmonary artery itself. They placed an IVC filter, and she fully recovered after 3 days. Now, most patients in this scenario, we would have just called it in the emergency department. It would have never taken her anywhere because she was in full cardiac arrest. And so now we're really kind of thinking outside the box and asking the question, you know, is there something more we can do with intervention? And so now Europe has kind of been leading the way in this. So Europe and actually Singapore have been leading the way in this. And this is a kind of a paper that was published, I think like 3 years ago, Paris sharing their experience. And so in Paris, on their ALS ambulances, they actually have physicians who ride along. And this next picture is showing you in Paris, they were responding. I got a little crazy there with the advancement there, but this is at the Louvre Museum. So this is the Louvre Museum. You can see all the expensive artwork in the background there. But they had a patient who had a vfib arrest in the Louvre Museum. They placed the patient on mechanical CPR in the museum, and then placed the patient on ECMO, or extracorporeal membrane oxygenation, and supported the patient from a cardiopulmonary standpoint while they transported the patient to the hospital, where they went straight to the Cath Lab for PCI. And so this is really a new movement. I know in parts of Asia and Europe, this is what's being done, is they're actually placing patients on ECMO in the field. And so ECMO, again, extracorporeal membrane oxygenation, the whole idea is you place 2 catheters, one arterial, one venous. On the venous side, blood will be taken out of the body. It'll run through a pump, which kind of acts like the heart, to bypass the heart, and then run the blood through an oxygenator, and then the blood will be returned on the arterial side. And we've been doing ECMO for years. I mean, I took care of patients on ECMO in the 90s, you know, mostly pediatric patients who needed cardiopulmonary support, you know, until we can get them a heart transplant or a lung transplant. And this is what we call VA ECMO, so venous arterial ECMO. Now, many of you might work in facilities that do VV ECMO, or venous ECMO, and we'll do that a lot of times for ARDS patients. But this is cardiopulmonary support to preserve the myocardium until we can get the patients to the Cath Lab. So there is actually a research group called the ERECT research group that's it's based out here out of the United States, and it stands for Extracorporeal Resuscitation Consortium. And the whole idea is to bring these facilities together who are doing a VA ECMO in, you know, cardiac arrest type patients, and to really kind of work together to look at outcomes, assess best practices. I know back in 2016, so a year ago, they sent out a survey to ECMO centers across the country, to 99 centers, and they had 70 centers responded, and about 36% of these centers were performing ECMO in the emergency department for ventricular fibrillation patients. Other findings is that they see that most ECMO programs are based out of academic and teaching centers. Most of these programs are actually pretty new. 65% of them are less than 5 years old. 60% of them perform less than 3 cases of VA ECMO for cardiac arrest per year. And then 40% of them are using mechanical CPR while they cannulate the patients and put them on ECMO. And most programs include their CT surgeons, perfusionists, and then of course pharmacists. And so Minneapolis, so Dimitri Yiannopoulos, who's out of Minneapolis, he's honestly been doing just some amazing work in Minneapolis and with their program. And so this is out of the university there in Minneapolis, and this is his protocol. So they're asking, is this a patient refractory vfib VTAC who meets the criteria? And so they'll put the patient on the Lucas device, and then they'll cannulate the patient, and they're just asking, inclusion criteria. It must have 2 of 3: end tidal greater than 10, PaO2 greater than 50, and a lactate less than 18. Then they'll go ahead and put the patient on VA ECMO. And they'll use a 25 French venous, 17 to 19 French arterial, and then they'll get these patients to the Cath Lab and try to get the culprit artery opened. And so last year, Dimitri Yiannopoulos had published his outcomes on the first 18 patients, and what they found was they had a 53% survival. This is actually pretty amazing, you guys. And most of them had a cerebral performance category score of a 1 or 2, meaning that they were neurologically intact. And one of the crazy things is when you look at troponins, a lot of these patients had troponins that peaked out at over 100. So very, very high troponins. And then what they did was they looked at their echocardiograms. So they would look at echoes during kind of the hypothermic phase, because a lot of these patients, not a lot of them, they get cooled if they remain comatose after their arrest, so they'll get cooled, and then they'll slowly rewarm. And what you can see as between like day 5 and 7, a lot of them are recovering their cardiac function, and they've got left ventricular ejection fractions above 40%, which is actually pretty amazing. And so some other things that they found that Dimitri Yiannopoulos found by looking at his data was that the 3 big things that had the biggest influencer on survival was A, a rapid EMS response time and transport to hospitals, B, that they got bystander CPR, and then C, that they indeed did have a coronary disease. So those were the 3 things that kind of were in common for those patients who had good survival. Now, one of the things I wanted to mention, there's actually 2 ongoing studies in North America right now. One is out of Vancouver, and the other is out of Michigan, out of Ann Arbor, Michigan. And so they're both looking at this whole idea of eCPR for refractory out-of-hospital cardiac arrest. So I just think it's really exciting that in the next couple years, we might have some more data to really identify, should we have designated cardiac arrest centers to, to take these patients who have this refractory vfib. And so what does AHA say about this? Well, they say, basically they give everything a 2B recommendation, saying it's reasonable to consider if you've got a cause that's reversible and if you've got staff that are trained to do it. So with that, I'm going to wrap up. So Chris, I want to get you ready, but I want to take questions from the audience. So Tim's going to come back online and we'll take questions from the audience. But bottom line is that we have to think of all this as a system of care. So, did the patient get early bystander CPR with, defibrillation in the field? Are we getting them to the hospital? Are we getting them to the Cath Lab for early intervention? Are we providing amazing ICU care? Because I can't say enough about that. And then hopefully the end product in all of this is that we'll get the patients home with intact neurologic and cardiac function. Okay, so with this, I'm going to hand it back to Chris Lux. So Chris, I'm trying to advance the slide here, but I'm not able to. So I'm going to give it to you. So there's Chris Lux. And we'd love to know what questions we've got.
Okay, Nicole, but before we do that, I have to go over a few housekeeping issues with the audience. As stated previously, this educational program has been approved for 1.0 contact hours of CRCE and CNE by the AARC, the California Board of Nursing, and the Florida Board of Nursing. To obtain your continuing education certificate, you will need to go to the website sacstesting.com/SL, which is listed on the slide that is on the screen. You'll need to register on the test site and complete the evaluation form. Upon successful submission, you will be able to print your certificate of completion. The accreditation statement is disclosed on the slide. It is also important to note that today's presentation has been recorded and an archived on-demand version will be available on savinglivesnow.org. An email will be sent to all registrants when it is available. The on-demand version will also be accredited for nurses and respiratory therapists. Nicole and Tim, I'm happy to report there's several interesting questions from the audience. And the first question is from John. John wants to know, does amiodarone or lidocaine really work to decrease recurrent vfib?
I can take that question. So thanks, John, for that question. So a couple things. Well, last year there was a study published called the ALP trial. So it was amiodarone versus lidocaine versus placebo in out-of-hospital vfib arrest. And when you kind of looked at everybody who so let me just back up. So what would happen is in the pre-hospital phase, patients would get, or the medics were given a syringe of something. So they would push a syringe of either amiodarone, lidocaine, or saline, and which acted as a placebo. But what that study showed, which was quite interesting, that there was no statistical difference between amio-lido or placebo. However, in the post-hoc analysis, what they did show is that if you were an out-of-hospital witness vfib arrest who got bystander CPR, there was some advantage to using amiodarone. And so the AHA has definitely not made any new changes. It's still recommended in the guidelines. So so for now, we still think in that subset of patients that amiodarone is helpful. And the good thing is it didn't show that amio or lido were harmful. So I think for now, we're going to continue to still give amiodarone.
Okay, the next question is from Randall. Will you be addressing escalating high energy doses above 360 joules, say 720 joules, by using tandem life packs?
Sure. I'll take a stab at it, and I'll invite Nicole to chime in as well. So, not claiming to have read everything that's ever been written on the subject, but to the best of my knowledge, there's no prospective trials on this. A lot of it was case study. So kind of the level of evidence is maybe a little more anecdotal. I don't work for any equipment manufacturer, but what I understand is that it's an off-label use for all of them. But having said those two things, I'm also fully aware that lots and lots of people are doing it. So the question comes, and I would think that the real first issue is, who is it we're talking about? Which kind of patients? And that was actually one of the main reasons that I spent a few minutes trying to differentiate recurrent versus refractory. And what I would hope that we'd be able to do is to just recognize that if it is truly recurrent, meaning the defibrillation was successful, then we wouldn't spend a lot of time attempting some alternative defibrillation strategies because, hey, if it's working at the existing level, then it's not a defibrillation issue. Something else is going on. And that was like the vast majority. And according to that one study, it's fairly large. It's probably like 0.5% would fall into that refractory category. So isn't a ton of evidence. It is off-label. Lots of people are doing it. And I guess my parting thought would be, if we're thinking about doing it, let's make sure we're aiming it at the right crowd. But I know Nicole has got a few thoughts on that as well. So why don't you chime in?
Yeah, I mean, I'm just going to echo. It is definitely off-label use, and you know, I've been kind of following this, and in the vfib population, like the case reports I've read, it doesn't look good. And so I don't know. I think you need to be really, really careful. And if you're going to do that, if I were you, I'd track your data. And I don't know. I think it's kind of a somewhat of a risky thing. I know we do it for atrial fibrillation in cardioversions. And again, it's off-label use, but I don't know. I think I hope if people are going to do this, that they track their data and really and maybe share their data and publish it. So I think that's all I'm going to say to that.
And probably the only parting thought other is certainly medical direction, and probably reach out to your equipment manufacturer for some of the specifics about that.
I would agree with that.
Okay. Nicole and Tim, we only got about 2 more minutes left in the webinar. So this is a question that was actually presented by Joseph and Andrew. For out-of-hospital cardiac arrest with refractory vfib, what are your thoughts on double sequential defibrillation?
Oh, that's what we just addressed. Yeah, so that's the other name for what we just addressed.
Yep.
Okay, how about for using Esmolol with refractory vfib?
Yeah, so again, there was a case series where they used Esmolol, and I think the bottom line is we just don't know. There's never been a randomized control trial using Esmolol. So the whole idea is you kind of block catecholamine. I don't know. I think a more interesting thing was let's question epinephrine. That's on to me is a far more interesting question. Is we're giving tons and tons of epi to these patients, and I think that should be questioned more than anything. I'm wondering if it's more harmful to the myocardium. There's been a number of just case reports before and after retrospective studies that have associated epinephrine with worse outcomes. And so I think the bottom line is we just don't know. And there is a study that's ongoing in the UK out of Warwick University where it's a randomized control trial where they're giving patients with out-of-hospital cardiac arrest and randomizing them to either get epi or no epi. And then Esmolol, I would just love to see a randomized control trial on it. I just think we don't know.
Okay. All right, everyone. Thank you, everyone, for the interesting questions you have submitted, but unfortunately, our time is up. It's been a pleasure to be your moderator for the webinar, and as always, Nicole and Tim, I've learned a lot from your presentation. I hope our audience has too. Everyone, Dave does have a few last-minute items to discuss before we conclude this webinar.
Thanks so much, Christine, and thanks to both of our speakers today, Nicole and Tim, for their insights into today's topic. Thanks also to everyone who submitted a question. If we didn't get a chance to answer yours, we will do our best to follow up with you via email if your question requires an answer. Now, Christine mentioned some of this already. Later today, you'll be receiving an email with a link to the site you'll need to visit to receive CE credits for today's webinar. In fact, that link is on your screen right now, saxtesting.com/SL. That email you'll receive will also include a link to a brief survey that we hope you'll take. We'd really like to know your thoughts concerning today's webinar. We really do read all of your comments and feedback, so please be sure to take a couple of moments to complete that survey. And finally, today's webinar was recorded, and you'll be receiving another email with a link to access that recording when it's available. So check your inboxes for that in the near future. Thanks so much for being with us today. That does conclude today's webinar. Have a great day.